So, I would like to start with this paper by the team of Padua, Journal of Hepatology 2006, to point out the fact that the BCLC, in reality, we may say that we don't like in some part the therapeutic output, but we may say, and we have to say, that among the most popular staging system, and the purpose of any staging system is to provide a prognostic revision of the course of the patients, is well separating the prognosis of the patient stratified according to the classification. Then it's a good classification. As a surgeon, we have always wondered about the fact that this is the one release on the Lancet. There were several starting from 2001, from Brooks and Louvet, and they replied this flowchart thousands of times, and the resection is always in this corner for very small, tiny lesion, and as you have seen, these lesions are quite suitable for a more conservative approach. Then a marginal role to surgery has been addressed, and we were concerning the real impact of this fact. Last year there was an update, but the update was only to change the name of medical treatment, targeting the medical treatment with one drug, and namely sorafenib. Still resection has a very marginal role. In 2011, the revolutionary update has happened this year. There are already two papers in which this flowchart appears in highly impacted journal, Lancet, this one, and the other one is the Journal of Hepatology, the same group, the same paper, in which it's a little bit redundant, and ablation finally substituted the surgery for this kind of patients with a very small, less than 2 centimeters. They have realized what Livraghi has shown in 2008, Livraghi and many other colleagues, Solbiati, Rossi, on Hepatology 2008, in which they were showing that the local control with the ablation for the lesion less than 2 centimeters was surgical, 98% of sustained complete response. Sustained complete response, this is the key point of when we have to evaluate the local control by ablation. We may say that in that year, we also reported on the archive of surgery, the same year, our flowchart. In our flowchart, we've shown that since several years, as a surgical group, lesion less than 2 centimeters were addressed to ablation treatment, knowing that in this kind of patient, probably the capability to provide an adequate control by the less invasive technique was surgical. But starting by the point that once we are facing with the tumor treatment of ACC, we have to consider this way of spreading inside the liver, satellite nodules and tumor thrombi. Then we have to provide something that is meeting this oncological requirement, which means that we have to remove the part of the liver in which the tumor is located, together with the branching pattern of the portal, the feeding branch of the portal system. This is not in contradiction with the 2 centimeter rule, because if you see that the microsatellites increase when the size of the tumor is increasing, and the microsatellites surrounding the tumor are very rare below 2 centimeters in size, by this paper on Cancer 2005. Indeed, when we try to compare the anatomical resection, and we explained what does it mean with the non-anatomical resection, this nice paper published on Surgical Oncology by a Japanese group. But well, there is no difference for the T1, for the lesion smaller. So then this is an indirect confirmation of what we have said, the paper of Livrag and also the microsatellites. They are unhappy of the undecided. Solitary lesion less than 2 centimeters, then for us ablation is in. This is just not for advertising the type of needle, is just the figure I found on the web. For when we are increasing concerning the size, concerning the presentation we heard by the pioneer of the radiofrequency, Alessandro Rossi, is, well, we have to say that surprisingly there are many papers in literature, and I don't find this paper mentioned too frequently in the lecture of the supporter of this technique, in which it is shown that the local control over 2 centimeters is quite unsatisfactory, and I want to point out the term of observation to decide if it is satisfactory or not, because you have to see, 1, 2, 3, 4, 5 years. Then the plateau is reached around 2-3 years, not 1 month after, not 2 months after. Then this is impacting also the survival of the patient once larger than 2 centimeters compared with hepatectomy. There is no difference once the lesion is smaller. And size, and paradoxically size, is a contraindication for ablation, because the rate of local recurrences or unsuccessful treatment increase when there is a perivascular location. This means in the case of lesion deeply located and judged by not the surgeon as difficult to be removed, which is not the case. Paradoxically, to this patient we can offer a better control. This is a randomized trial, of course, on a surgical treatment, surgical paper. The top paper in our ranked journal, Annals of Surgery, not so dated, is 2010. Well, this is the recurrence, local recurrence of radiofrequency ablation and resection in a randomized trial. And the Chinese group, big numbers, 120 versus 120. And compared to the previous one, there was another randomized trial, Annals of Surgery always, there was no difference but 3 years survival. This is a 5-year survival. And whatever you can see, there are differences in terms of survival and disease-free survival, both for small, large, multiple lesion, always the same. Anyway, we may say that caution has to be used when you are increasing the size of the nodule. You cannot, pioneeristic experience can be accepted, but when I see judged unresectable patient, I am still concerned about the judgment. Who did the judgment of unresectability? For the other tumor, for the larger tumor, we need to remember the tumor spread. I'm speaking about the local control, and not about the disease in terms of rate of recurrence, distant recurrence, the natural history, but the local control, which is the question to which any doctor asked to give a local control of the tumor should answer is we have to remove the territory in which the tumor is included. And this paper, Anasosurgery 2005, by the group of Professor Makuchi, Tokyo University, they proved that segmentectomy and then anatomical resection is important for dividing the prognosis and providing a better control in terms of local control. The concern about the surgeon, the surgical applicability, especially in the western side of the world, and I agree with the Japanese colleague, is the fact that when we have to remove a tumor, we have to remove too much liver, and we know that this means a higher mortality and big problem. Indeed, it's unbelievable, but I may say that when I attend a surgical meeting, the Northern Europe and the North American surgeon provide totally inadequate level of mortality and perioperative morbidity. I mean, the range is over 5%. Then in this way, because they are too concentrated in big removal of the liver, 45% of the series in the Western countries. The major hepatectomy can be avoided, but it can be still an anatomical resection, as Makuchi was teaching us 30 years ago. So it's not a big news, and we can tailor the anatomicity of our removal compared to the location of the tumor. And this can be done with the same device that you are using, the ultrasound. Instead of ablating, if the surgeon knows how to use the ultrasound, he can do the resection for removing anatomically. This is a technique that we devised, and is just a compression, quite simple, and we can remove the territory without a big problem. This is before and after the compression. You see the marking area of the liver, and you remove with the targeting point that you are doing an anatomical resection, exposure of the hepatic vein and the pedicles. This is a segment 7. It was published on the Annals of Surgery in 2010. Then liver surgery is evolving to conservativity, keeping the radicality, even accepting for the ACC the zero margin. Once you are doing an anatomical resection, you can consider that the zero margin is acceptable, because the important aspect is that you cut the portal tree feeding to that tumor. Indeed, once you have an exposure of, like in this schema, an exposure of the tumor in contact with the hepatic vein, like in this one schematic appearance in segment 8, and here there is a satellite. All nodules that belong to that segment, which are the only satellites you have to consider, will be included in the specimen. If there is an undiscovered and undisclosed nodule in the fourth superior here, it's quite adjacent, 2 centimeters, 1 centimeter on the other side of the liver, of the middle hepatic vein. But if it belongs to the segment 4, he grows up because the tumor cell migrate from here to here. So this tumor is the same of this one. It's a distant metastasis, not a local recurrence. For the distant metastasis and the undisclosed lesion, you may use the contrast, but this is not fundamental. And in this sense, probably Japanese has the answer. They can use the sonazoid, which will improve our capability to differentiate the nodules and then be more radical in the resection. Exposing the tumor doesn't mean exposing the local recurrence. This is the rate of the local recurrence of surgery is 1.5%, not the rate that you have seen previously. And the range of the mean follow-up is 29 months, so it is quite adequate. And for all the other lesions, intermediate, advanced, are we sure that we have to provide only palliation? This is the answer. It's only sorafenib. This is the paper all of you knows. There are plenty of recall of this paper. we may say that this paper of Hepatology 2011, which is sustaining the use of sorafenib, let's see the adverse event of the use of sorafenib. Any grade of complication, 91% of patient has at least one adverse event, and 45% of them are the severe adverse event after ablation. It is so heavy, this problem, that even with this nice paper published on Lancet Oncology by the group of Guido, they were showing that comparing the survivals among the sorafenib and the liver transplantation for the advanced and intermediate case patients, there was a benefit, and they even proposed the use of transplant rather than sorafenib for the BCLC B and C patients. But there are some concern about the transplantation. Only 1% of the patients receive the transplant in Italy, according to this very nice paper published by the Italica group on the European Journal of Gastroenterology and Hepatology this year. And there is another nice paper in which, based on the intention to treat, the system is showing that transplantation and resection is not so different once you are including those patients who are dropped out during the waiting list. And this is the outcome of this patient who could not receive the liver transplantation. This is the recurrence curves. And if you compare, according to the MED, the Milano or UCFS criteria, there is still, based on the intention to treat approach, not a big difference. And also for the local recurrence. This is a paper appeared in 2001. Then the key factor is ultrasound guidance, being conservative, technical skill, liver skeleton to be kept, and ensure the inflow and outflow to provide new solution, detach the tumor from the vessel, as we shown in 2005 and 2006, and then affording also the so-called centrally located tumor like this one. I challenge everyone to say that this is not a centrally located tumor. It's in the axilla between the P58 and the P67 in contact with the vessel without invasion at ultrasound criteria. And the removal of the tumor is only this one. So it's a local control, radically done, with the central position, cannot be afforded by ablation unless you don't want to damage major vessel. Or having caution also to ligate the vessel during the dissection, we can monitor our approach and then reduce in this centrally located tumor the rate of sacrifice of liver parenchyma, and then providing local control with the lower sacrifice of parenchyma and then extending our indication. And another aspect is using the contrast, the flow for this tumor. We just do for 10 of the patient receive major hepatectomy. Then new operation has been devised with this technique. And half of the patients we treat are BCLC B and C normally. This was published in 2008. This is the update of our series. Mortality is 1.2% at 30 days. This is the survival of the BCLC B and C. And look at the rate, it's 46% at 5 years and 37% at 5 years. Well, if you compare this data with this paper, which is going to be published on nanosurgery, we collected patients from the MD Anderson, Johns Hopkins, Tokyo University, Nihon University, and Paris University, and Buenos Aires, Argentinian, 2,046 patients, 746 from Asia, 367 from United States, America, 993 from Europe, and half of them were BCLC B and C. So in the surgical department of surgery, the Federal Center, the BCLC B and C is routinely operated. And 10% of them had varices, so portal hypertension. These are the survival curves. And the rate of survivors at 5 years in a Kaplan-Meier curve is 57 and 38, which is the same of the previous slides. with this kind of disease-free survival. This is a paper which I guess should impact, especially if you compare the outcome of the patient, less than 40% and less than 20% BCLC-B and C at 2 years with sorafenib only. This paper is the one that I mentioned of Iavarone on Hepatology 2011. Then we are promoting this flowchart. For the intermediate and advanced surgery, don't skip the surgical evaluation done by a team which is expert in liver surgery, devoted to liver surgery, because resection can be an offer and provide a good prognosis for this patient. Best risk-benefit for RF in ACC less than 2 cm, better local control of surgery for larger ACC. Surgery versus all liver transplantation has to be revisited according to the, this is the latest release, the one I showed, but there are several before. Surgery should be considered for BCLC-B and C ACC. It's not a dogma in terms of therapeutic output, and this should be stressed because many hepatologists, many doctors in the local hospital has to follow this as a dogma, and multidisciplinarity is mandatory, although multidisciplinarity is banded by the strength of the specialists that are working in the hospital. Where there is a strong surgery, every patient is addressed to surgery. When there is a local in the hospital of Sandro Rossi, probably no one is going to surgery. Thank you very much.
Thank you, Professor Torzilli, and the compliments for your fine and balanced presentation, in my opinion. But my opinion is the opinion of the surgeon. So if you have any question for Professor Torzilli? No question?
I have two
Surgeon?
No, I have two questions.
It's natural.
No.
It's a good thing that the public has no question.
Philosophical question. One question is, why the surgeons of Europe, of United States, of America, for instance, or Canada, of course, because we have a person from Canada, after 20 or more years, after the results of Madatoshi Makuchi, don't use this method. Why we are talking about this discrepancy now after 20 years? Why they didn't follow?
You should ask them. Anyway, I think that there are two reasons. One is the fact that the procedure proposed by the Japanese School of Surgery is a long procedure, anti-economical in some part in the perspective of the North American hospital, in which right hepatectomy 3 hours is okay. The average length of our operation is 6 hours. And the other aspect is, when I was there, and I stayed 2 years with Makuchi, when I have never seen a North American surgeon passing there. A lot of European, but no one. Then I think it's not in Canada, but in the US, there is a big quality, great country. I love the United States. They gather the brains of many challenging persons, but the limitation is that they believe they only the world, even the baseball, the basketball tournament is the world championship, not the North American championship. So in this is betraying such kind of approach, and they don't travel to see the other. And in particular, I mean, in terms of surgical oncology, they have to learn a lot, and we also European, from the Japanese school. The kind of approach is more suitable for the oncological approach because it's calm, long, don't care about the thing, done, precise, well done, and this is the only way you can face with the cirrhotic liver. The only way. Otherwise, you kill the patient.
I remember I was in the operatory theater with Masatoshi Makuchi, and he wanted to show me that the patient had 8 small hepatocellular carcinoma in different segments, and he wanted to demonstrate the possibility for surgery also in this presentation of disease, and he said, for me, the resection of an hepatocellular carcinoma is like to take a stone from the sand. That is very easy. It was very exciting to see Makuchi removing all the 8 lesions. The second question is, okay, you answered about the problem of North American colleagues, also European, but when the VCLC was proposed, why the authors decided that surgery could be useful only for very, very small tumors? Which is the explanation why they didn't expand the indication for tumors, I don't know, 5 centimeters in size.
But as you know, the BCNC is provided by the Barcelona group. There were other doctors, but the vast majority were hepatologists.
Bismuth was one of the experts.
Yes,
on
but
that occasion.
is a great surgeon, very smart. In such a context, probably judged his presence not so popular to be too against. And in some part, the French surgeon, when you see the Paul Brousse experience, the mortality of resection for ACC is 8%. 8%, from 6 to say 8%. So I can understand in the perspective of the highly qualified world of liver surgeon from France, is that because they promote still a conventional way, in spite of the use of ultrasounds in several years, which they copied from the Japanese. But anyway, it is not in the real fact, in the real routine. They used to do right hepatectomy.
How many centers are able to perform high-level surgery? As you
High-level surgery is done by the team in France. So, I mean, tertiary referral surgeons center are providing high-level surgery. It's a philosophical approach, which is quite different, and the results are, in terms of safety, different, but probably also the possibility to provide a therapeutic solution, surgical solution to the patient. But anyway, I cannot say that the Paul Brousse are not, I have nothing compared to them, and then they have a big tradition. It's a new way of thinking that should be afforded with caution by those surgeons that are not accustomed to use the ultrasound in this way. And I think that we have to look not at the 60 years old surgeon, not at the 50 years old surgeon. We have to look in the fascia between the 30 and the 40. This surgeon, I am sure, in the next 10 years will provide several reports, even in the Western countries, showing that with the ultrasound you can do better results, and you can, limiting the volume of resection, you will expand, especially for the metastatic disease, the use of surgery. It's a question of generation. You need to be trained 10 years to be autonomous. Then it's time. You cannot ask to a senior surgeon to start with ultrasound. He cannot admit that it's logical. I would be the same if tomorrow someone will say to me that I should use another device, very complex. I have 2 chances: continue my way or retire.
So So the conclusion is that if the patient is from France or United States and the patient has a tumor 4 centimeters in size, it is better radiofrequency than surgery because the mortality is 8%.
No, for the
The
IVD,
message
mortality is not 8%. But
No, 8, not 8. Should be 8%.
No, I may say that we have to be clever enough to understand that the progress is towards a more conservative approach than trying to, fight against you that are providing so good results for very tiny lesion is out of the time. Not, we never prove that we are better. So then for the patient, I guess that is the advantage. For the other patient, I have a lot of concern.
Don't you think that the answer to what Tito was asking for, why no surgeon argued about against the so limited role of surgery in DCLC on that can depend first in the last 10 years, 5 years, even 5 years, all the device for even for surgeon are getting more allow you to have a faster surgery. Probably you don't love it, but you must think in the habit of other surgeons that don't want an 8-hour surgery.
They should not do the resection. If they don't want, they should not do
don't be
the
so strict. So I think that innovative
cut-off is less than 2% mortality. You cannot accept more.
Okay. And the other thing may be that nobody argued about this also because of the pressure and the willing of a new therapy and a more simple therapy like chemotherapy, but also the fact that the high number of recurrences even after surgery seemed to be a failure, and so there was this kind of thing. And this is a question for you. But the other thing I would like to stress that because we have a gastroenterologist, oncologist in this room, that is that surafenib is now. We see a lot of patients not in advanced stage, but even 4 centimeters single node that are sent to, I'm an hepatologist, so many hepatologists, many gastroenterologists, and oncologists to see this patient 4 centimeters single node sent for sorafenib. This is should be stressed. This is a malpractice that someone make on many patients with this disease.
The first question, I may say that the device is not changing the quality of surgery. We do the caliclasia without any device for burning the liver in the 2012, and Makuchi is doing the same still now. And still in safety are the best treatment, are the best results. Scientifically proven, not this I'm claiming because showing my thorax. It's not a bullshit of such kind of, it's comparing the results. And if the results is valid to provide the flowcharts like the BCLC, we should consider the results in terms of safety compared to devices. And you have to spend the time. Reduce the blood loss and be conservative. This is the three. So then if you do this, you can offer. And I must answer why the surgeon didn't do. In reality, 2003, surgery, tumor thrombosis, proven 42% of survival at 5 years. Tokyo University experience, 2003, but it was the experience of 10, 15 years before. And the BCC was released in 2001, so they were completely neglecting. Bruins visited the National Cancer Center, and they were invited when I was there in Tokyo to exchange. The other aspect, 2008, we published an archival surgery, the same here, gastroenterology, Shishizawa, published a paper, portal hypertension, tumor thrombi, there were benefit in terms of survival. Cucchetti, Bologna team, portal hypertension, there is a benefit. The surgeons are publishing. You know, the way of, our way of saying we are not in agree with your, is the publication. There is no other way, no? We cannot fight. But the problem is that we read the pathology, we read journal of pathology, we read journal of clinical oncology. The oncologist doesn't read advanced surgery, archival surgery. This is the reality. This is the fact. I show it, just 1 second. When I am in the meetings talking about the metastatic disease, I saw very famous and highly impacted oncologists that citing JCO 2008, 2010, they wonder, you see, surgery is able to provide the long-term survival for patients with metastatic disease from colorectal cancer. It is well known in the surgical literature since 20 years. The first paper was published in 1984. Analysis surgery, providing long-term survival at 30% for metastatic disease. They still wonder now. It means they don't read our literature. It's a big problem.
What about resection for recurrence? One more on this. Resection for recurrence or
In our series, I cut the slides. We have 45% of patients who receive a local treatment for recurrence, and 16% of them were radiofrequency ablation. All the others were recurrence. And keeping the skeleton, of course, we are speaking about child A, but sorafenib should be administered to the patient in child A, not in child B and C. It's a paradox. Well, we have the possibility to retreat, and in this sense, ablation is helping us.
Thank you for a great talk. A question and a comment. First, same problem in radiation oncology. Only radiation oncologists read the radiation oncology literature, so it's difficult for others to be aware of it. But my question is regarding a learning curve. For the type of surgery you have, are there a minimum number of cases? How does a hepatocellular carcinoma surgeon become expert enough to do the kind of surgery you described safely?
This is the, at first I want to say that probably you are representing those who will cancel us, and I also probably, and also ablation. They don't realize, but ablation probably is already, you are already finished. But anyway, we have the true beam in our hospital, probably the same you have. It's fantastic. And in the second, concerning the learning curve, of course, is the problem. But it's a cultural problem. I mean, it takes to make, to me, 10 years to have a completely equipped surgeon. It means, but for any kind of advanced surgery. So this is not this technique, but depending on the philosophy of the school, if you are North American, North European, Asian, it takes for you to be able to face with most of, the vast majority of the cases, autonomously, 10 years. Indeed, the golden age for the surgeon is between later than 35 and less 50. I'm at the end, 49 so. And in which you are strong and you can, but this should not be considered, I think a limitation should be a recall for those who are trying to do a shortcut. You could not avoid this kind of long training. Using an example, ablation intraoperatively, to be addressed as a surgeon. You must be able to do it. Otherwise you shift the indication.
Excuse me, but however, it's not only the question the level of surgery for hepatic resective surgery. It is too the question how many in Italy are thermoablators at high level? Not so many. It's Libreri, it's Tarantino, and after much more. Not much more. Well, the question is high level have to be compared with high level. Yes? So, as consequence, the next presentation is from Professor Librari, who present very early hepatic cell carcinoma. Radiofrequency can make it better than surgery. And note, there is not a question point. Well, thank you.
Okay.
May I ask?
Yeah.
Yes, you can.
No, I'm sorry. Thank you. My name is Kawam from Japan. I asked about your survival recurrence curve between ablation and surgery, and you showed long-term result is very good for more than 2 centimeter HCC. What is the difference between surgery and ablation? My thinking is sometimes for ablation the HC cell go to hepatic vein or portal vein, and after long term it recurs. So it's cause a difference. How do you think?
For me, the difference is the local control. In terms of probably the distant metastasis inside the liver, this could be a logical perspective to the spread, but also the manipulation could be also the source of spread. And then I think that it's the local control that is changing. When you are, they cannot be microscopic in the control. The system is gross. The imaging, they have to wait 2-3 years to understand if they were radical or not. In this way, it's, how can you propose a treatment to honestly to a patient and say, we will know if we are really radical in 2 years, 3 years. I am sure that if you speak like this to the patient, the rate of unresectable patient will decrease dramatically.